Good afternoon, and thank you for joining USACE's senior leaders for today's webinar discussing the U.S. Army Corps of Engineers COVID-19 response. We greatly appreciate your attendance today in support of our response efforts. Before we begin, I have a few things we'd like to point out. Please ensure you have your WebEx participant and chat panels open by using the associated icons located at the bottom of your screen. Please note that all participant connections are muted at this time. You may submit written questions throughout the presentation, and these may be addressed during the Q&A. To submit a written question, select all panelists from the drop-down menu in the chat panel, enter your question into the message box provided, and send. While we may not be able to answer or respond to all questions during the event, we will be reviewing questions and will post responses to commonly recurring questions after the webinar. If you require technical assistance during the webinar, please send a chat to the event producer. With that, let's begin. The U.S. Army Corps of Engineers is currently undertaking efforts to support FEMA, state, and local authorities to respond to the COVID-19 outbreak. Among these efforts is assisting other agencies in assessing potential sites for suitability as alternate care facilities and to rapidly engage contractors to prepare selected sites for medical use. This presentation will give an overview of the U.S. Army Corps of Engineers efforts to date, as well as the challenges and opportunities presented and what construction contractors can do to help with these efforts, as well as all of our industries that support. With that, I'll turn this over to Dr. Christine Altendorf, the Chief of Engineering and Construction Division.
Good afternoon, everyone. First of all, I would like to thank you all for taking time today. I know everyone is busy, if not with work, at home, trying to figure out how we're going to get through this really crazy crisis that we're all in, and really how we're trying to figure out how to function in a very abnormal situation. So I really do want to thank you for your time. You know, what we're trying to do today is really just share information with you. Things are moving very, very rapidly. We are learning as we go along, and we just want to have these forums with you so we can share what we're doing so that you're aware that we're not trying to do anything in a vacuum, and we're trying to be very transparent. So I'm going to give a brief overview to start things off, and then we're going to move into the concept of operations with Mr. Mike Schultz, who's the Chief of Interagency and International Division here at headquarters. And then we're going to have an overview of the conversion concept. So that's actually going to be our designs that we put out for alternative healthcare facilities. And then finally, we're going to get to, I think, probably one of the topics that you all are most interested in, which will be our contracting considerations. And that's going to be led by Ms. Jill Stiglich, who is our Chief of Contracting here at Corps of Engineers headquarters. So next slide, please. So as I stated briefly, we really are trying to be transparent and share what we're doing and what we know. As I stated, all of us are in a learning mode right now as we try to work through this. How we came to decide to do this is to power down to our regions and to our districts and really try to decentralize the execution of this task that we've been given. So what we did is we came up with some concepts that we worked with Health and Human Services, and we came up with some concepts, and we're going to get into the details of those conceptual designs shortly. But we came up with those. We got approval by Health and Human Services, and then we actually put those out to the region. We put those out to the field, and then the regions, the divisions, the field, they actually then have been working with their state and local communities because this is a FEMA mission, and we are supporting FEMA for this mission. So we're not doing this out on our own. Any money that we have for this endeavor is coming through FEMA. So because of that, the states are the leads in everything that's going on here. There's going to be instances where the Corps of Engineers takes the lead, and we actually then are doing the construction, or we're awarding the contracts. But in many, many cases, and probably a majority of the cases as we continue down this path, the states and the local municipalities will be taking the lead and trying to figure out what's best for their area and using their contracting capabilities that they have on hand. So right now we're working very closely, and like I said, we're trying to provide whatever support we possibly can. So the bottom line on that is that we've been tasked. We're doing everything we can. We came up with some designs, and then we're working with the states, and we're allowing them to use this if they so need as a support to FEMA. And then bottom line, the states and the local governments are the ones that make the decisions. So I just want to make sure that everyone is aware that that is how that is working. Next slide, please. So to give you an overview, right, we have a placemat, and the placemat, I believe, is actually on some of our websites. This placemat is updated every day, and I will tell you, even it can kind of lag a little bit. So you'll see the numbers here, and there'll be a number later on that you'll be looking at a list of awarded projects, and you'll say, oh, well, this shows 20 and that says 21. And it's because it's a moving target, and we try to keep everything updated. But sometimes you get information that comes in the morning, and sometimes you get a little more information that comes in the afternoon. But bottom line, we've been tasked to do two different things. The first thing we did, and the district commanders, along with their staff, have worked brilliantly at trying to get out and work with the states and local communities on doing initial assessments. So the assessments were what we were tasked to do is just to go and look at a variety of sites, what might be a good location to have one of these alternative health care facilities. One, the state and the locals have to determine, you know, is it going to be COVID, non-COVID, you know, is it for, you know, which then impacts what the design is going to be. So to date, we've been requested to do 1,077 assessments, and we've completed 901 assessments. Needless to say that they're not all going to be used. Some of them basically are no-goers from the beginning. Some might be put on a back shelf, but out there to say, hey, is this school, or is this hotel, or is this arena, or is this, you know, a baseball park, or whatever the case may be, or is this old hospital that is closed down? Are these something that actually could be used? So that's what those assessments are all about. Also, if you look then at the next column on this placemat, you can see what the Corps of Engineers has awarded. Now, this is not what the state has awarded, but this is what the Corps of Engineers has awarded for these alternate care facility construction. This shows 20, and I'm telling you down the road when I believe Mike Schultz is talking, the chart's going to show 21. But we have actually awarded 21 awards so far in a variety of states across the United States. So those are moving, and these take anywhere, we're noticing anywhere from about 5 days to about 2 weeks for construction, because as you can imagine, time is of the essence. We've got to have these available because it really, you know, it's about having beds for people to go to when the hospital beds run out. And so with those 20 contract awards, we're looking at about 15,706 beds. With the additional award that I talked about, that's going to show on another slide, we're at about 17,000 beds available. And another thing, that's a bit of a moving target too, because as we get these things going, and there might be a change of a decision that, hey, we want to change this from COVID to non-COVID. You actually can have more beds when it's non-COVID. When it is COVID, you have to have less beds because it might require much more intense medical equipment, et cetera, and medical oversight. So anyway, that's what we're doing right now, and the thing that makes this most challenging for us, to tell you the truth, is historically when the Corps is tasked by FEMA to respond to a disaster, it's usually regional. It's usually a hurricane or a flood or something of the sort, and we're able to actually take manpower from one part of the country and push it over to another part of the country. As you can see, our engagement right now is in all 50 states and 5 territories. We're in our 27th day of response, and so things are pretty busy here at the Corps of Engineers. And not to mention, we are continuing to actually execute our regular program. Yeah, you may wonder how that's working, and a lot of you actually maybe are contractors that are doing either civil works or military construction for the Corps of Engineers. As you know from the administration, they actually have pushed that infrastructure construction is mission essential. I know you all have challenges. I know we've had challenges. If an installation is shut down or states have the stay-at-home rule, how is it that you execute some of these projects that aren't COVID-related. And so we're working through that, too. We're making sure we get guidance out, but everyone is challenged with how we're trying to deal with that. But right now, our push is to continue, if at all possible, construction. And I can tell you right now, as I do come into the office every day, and I can tell you that there's a lot of construction going on in downtown D.C. because it's a great time for that work to actually occur because there's nobody around. And I know construction's pretty full and fast going on in downtown D.C. Now, granted, we've got to make sure that your staff and our staff are all safe and that we're doing the right things necessary. So just to give you a quick number right now, and these numbers, we're trying to get more fidelity on. They're changing too, but I just want you to have a feel of some of the impacts. Right now, in our data system that we use for construction contracts, it's RMS, we show that we have 2,798 contracts, and out of that, 568 are delayed right now because of COVID reasons, and we have a variety of reasons that we code in. So right now we've got about 20%. That'll probably go up, but I just wanted you all to be aware of we are keeping tabs on that, and we're pushing that also down to the field, and we know that our construction offices, our construction officers, our area engineers, resident engineers are working all of those on a case-by-case situation above and beyond the work that we're doing for the COVID. So with that, that's a kind of a lengthy overview. I hope I didn't go on too long, and we'll go ahead and I will transfer over to our next speaker, who is going to be Mike Schultz. So we can move to the next slide. Mike?
Good afternoon, everybody. Again, this is Mike Schultz. I'm the Chief of Interagency International Services here within our Military Programs Directorate here at the headquarters, USACE. The chart you're looking at that we have displayed for you currently is the concept of operations as we moved into this effort here for the responding to the COVID-19 issue that's impacting the entire U.S. and, of course, around the globe. The overall concept is really a centralized concept that was developed with decentralized execution that's happening down in our regions and districts. What's displayed there is really a concept that involves four main phases as you move from left to right, which is the plan, build, supply, and staff. We've articulated as we've laid this out that the planning phase, of course, is all a state and city lead with assistance from USACE as they think through that process on the ground out there and the need and the requirements that they have based on the impact that virus is having in their particular region. The build phase is all on USACE, or more importantly, can also be executed by the state and city leads. And so there's an opportunity that could go either direction. The supply effort, of course, is once it's built, is all on FEMA, HHS, the state and cities, and what we're seeing today is even DOD medical assets are being added to the fight as we're all dealing with the virus across the nation. And then lastly, staffing is all on the state and city leads, and again, we're also seeing as this is developed, the DOD medical assets are being thrown into the fight here as well. But they're the overall sort of four concepts. As you look at each one of those concepts, what's laid down below is really 8 critical steps that are involved. All of those are captured there in the words below. Most are all accomplished by others, but we're finding as we've moved through this process from day one, there's an integration role that USACE has taken on for a lot of our efforts out there. As the concepts have been put into practice on the ground, we're finding ourselves more and more involved in an integration role to bring all the players together, ask all the right questions, make sure all the right areas are being pursued as we try to implement this. There are 2 key roles that are involved in USACE specifically, and that, of course, is earlier conducting the site assessments early on to support the local site selection process that the states and cities are going through, and I really assess if the medical requirements can be met by each of those facility assessments that we do in each of those facilities we look at. In particular, we're looking at patient load, proximity to the hospital and support elements that are co-located or near these particular sites. Utilities, air infiltration and handling is a critical element of that assessment, of course, safety and code requirements out there, and then looking at transportation, staging, and parking as we go through each of those assessments activities. And then once those assessments done and the local, either state and cities, have made their site selection and made the determination of what sites they want to use, then we're involved heavily in to convert those sites for alternate healthcare facilities. Overall intent as we went into this concept with approved sites out there was building these adaptations in a window of 5 days to 2 weeks. We want to align with the state in their projected virus infection peaks, and that's an element that changes almost daily based on the model runs that are occurring out there. Emergency contracting authorities, both local and regional firms, involved big time in delivery of this, and also the fact that either we can do the contracting for this or we can hand those sites off and this concept off to the state and locals for them to be able to execute. And we're seeing a combination of that being applied on the ground out there. So as we look at activities today, so where are we at today with this response? As was mentioned earlier, we've got about 52 major disaster declarations across the U.S. and the territories out there. What we're seeing, there are a few states that have a little bit of activity out there, but not as significant as other parts of the region, but we're fully engaged in almost every part of the U.S. and many of our territories out there. There are 15,000 USACE team members that are currently engaged in this fight, and over 2,000 of our employees are deployed in various hotspots and mission assignments so far that are pushing upwards of 40 mission assignments and just under $2 billion worth of effort out there as we're executing today. The early planning process that we jumped on immediately in implementing this concept involved the site assessment requests from the states and cities out there and the governors. We've done 10,077 of those assessments have been asked to do. Right now we've got over 900 of those completed, and most of those have been in the arena to healthcare conversion or hotel to dorm conversion activities is where the principal focus of those sites have been. Recently employed a couple of pilot efforts to do some container conversions to healthcare. Those are going on currently in Detroit and will shortly occur here in the Baltimore, Washington, D.C. area to try a different version of the concept here as we apply to look at sort of a containerized solution to some of these sites. And as I said before, we're seeing an awful big role for USACE in the integration effort to try and bring all of the team members together, and particularly as we look at these sites and what needs to be delivered there, beyond just our efforts in trying to build the sites themselves. Next slide, please. This is just a snapshot. It changes almost hourly on us, so you're seeing sort of our first or current push effort that we're looking at today. Today we've got 21 contracts awarded to date. That's almost 16,900 patient spaces, and I use that term intentionally because as we were originally talking about beds, that was beginning to confuse a lot of folks because what we're talking about building here at in the sites is patient spaces. The beds and all the equipment, of course, is part of that supply and staffing component that is a responsibility of others, and we don't want to confuse that. We're immensely involved in 4 different regions, multiple states, and in many of the cities, large cities across the U.S. Currently, about half to 2/3 of these projects, the construction is currently underway. There are 4 of these that are quickly nearing completion. The Javits Center in New York City. There's a center in Detroit, one in Chicago, and then another center in New York are quickly nearing completion and ready for patient ready. As we develop these contracts and are working these efforts, they're a combination of both COVID and non-COVID use. But what we're finding today as we begin to continue to execute this effort, we're changing how these, they may go in originally as COVID or non-COVID spaces, but then as they take a look at the patient load and the requirements on the ground, in some circumstances, we're changing those in midstream and moving them more to a COVID adjustment. And so it's a really fluid situation out there, both for us, our contractors that we've brought on board and for the state. We're also involving our design and construction partner in DOD. NAFAC is helping us immensely in our efforts in Guam to deliver a similar concept out there for their situation. There's another 16 sites or contracts that are pending right now, just a little over 5,500 patient spaces that are either in the build decision and soon to be actioned here within the next couple days. And the goodness in this concept, as I pointed out earlier, is we could execute this, or our state and local partners could execute this. And so we're finding the state and city execution off our concept and design concepts that we developed. There's about 20 different sites and about just under 7,000 patient spaces that the states and cities are delivering under their contracting capabilities as well. As I said before, the situation remains extremely fluid as we work through this. Models are updating infection spread and peak timing projections almost daily. COVID, non-COVID decisions for space utilization are being assessed even as we build some of these, and supply and staffing availabilities and decisions have to go hand in hand with this, and many times that drives the site selections and also drives what we're building on the ground out there. And many times this is resulting, what we're seeing today is resulting in contract changes. In some cases we're about to cancel contracts and shift and lift fires and plan adjustments on the ground. But the concept that we developed and the way we're executing this remains extremely flexible and adaptable on the ground as our districts and regions are executing this with our local partners out there. And particularly we're able to, based on how it was originally, we're adjusting almost on a daily basis as well, based on the lessons that we're learning as each of these gets executed. With that, I'd like to turn this over now to Wade Doss from our Huntsville Center, who will talk a little more specifics about what this concept means on the ground.
Hey, thanks, Mike. I appreciate it. As Mike said, I'm Wade Doss, the Director of Engineering at our Huntsville Center, and some of my team, along with efforts all across the Corps, came up with some of these initial concepts. So we can hit that next slide, please. So Mike talked about it, but the first thing is trying to find an acceptable facility, and so that is part of the plan or the site selection phase, and that is a decision made by the local authorities. However, we did come up with some facility assessment checklist and some things to help them look at optimum sites. And what you see in front of you is some of the high points of those checklists. Certainly really important is trying to be within 10 miles or 30 minutes of a established permanent medical hospital. ADA compliance is important, as well as the ability to have those supporting functions like the medical has waste disposal, linen laundry, and pharmacy supported at these alternate care sites. So as we look at hotels and arenas, looking at facilities built after 1990 is important to try to mitigate lead, asbestos, paint issues. We're also really interested in the particular configuration of their HVAC systems, whether we can get negative pressure in a room or a floor is important. The layout of the hotel rooms and the bathrooms is important. So this is just a few excerpts of all the things we tried to look at in our assessment checklist and assist the states and the local authorities in identifying the absolute best sites. We'll go to that next slide, please. So the very first lesson we learned about 2 weeks ago is terminology matters. It really matters in the engineering world, and it certainly matters in the medical world. And as everybody knows, these two worlds have collided in a very rapid manner to respond to this COVID public health crisis. So our team tried to come up with a matrix and kind of we're calling it a terminology primer that you see in front of you. Whether when we're having these initial discussions with the state and local authorities, we really got to go through this chart and make sure we understand what the requirements are. They help us define the requirements on what kind of space we need to provide, whether it's COVID positive or COVID negative, whether it's acute or non-acute. The acuity of the patients matters because that drives all of the medical requirements, whether you need med gas or whether you need ICU type environments. So this is important, and I'll just pause for a second to let people absorb that chart. All right, next chart, please. So before I get into this particular cartoon or sketch, what we did was really tried to identify, and I don't use the term design a whole lot, really standard concepts probably better. We tried to look at standard concepts for hotels and arenas, and what we did is draw these things out. I'll go through a few of them here in the next couple of charts. But more importantly, along with these concepts and cartoons, we developed performance work statements. And those performance work statements are driven around COVID or non-COVID, acute or non-acute, depending on the scenario. There's a different performance work statement. We also came up with draft equipment lists. Just to reiterate what Mr. Schultz said, the ability or the task to provide the equipment in these areas, the medical equipment, is not USACE's, but we certainly have to know about what's going to go in there to modify the facility. But HHS and FEMA lead the effort on equipment. So we came up with draft equipment lists, notional schedules, and other engineering and construction artifacts that we intended to be used as starting points for our local USACE divisions and districts and our local contractors like yourself. Use those to develop the contract documents and to further definitize designs and tasks for converting these arenas and hotels into alternate care facilities. And so I want to make a point here that, there's not enough time to do traditional designs, but we certainly are going to have designer of record folks involved with our constructors and our AEs, and they're going to be working real close and have been with the local authorities having jurisdiction. So there's sort of a joint risk management there where when we're looking at NFPA, life safety, and or fire protection issues, that AHJ is going to be critical, and they're going to step up and make some decisions on code and criteria for these temporary facilities. So what you're looking at in front of you is a notional sketch of a hotel room. In green are the things that should be there in any typical hotel room. In purple are the things that we tried to identify at a high level of engineering changes, construction changes you'd have to make to that facility. And then in red is the medical equipment. These are built around worst-case COVID patients. That's why you see things like a spot for a ventilator and the telemetry pump, IV, et cetera. On the engineering changes, it says remove carpet and install vinyl. That is really going to depend on the scenario you're designing for. If it's non-COVID, non-acute, we're finding that folks will leave the carpet in the hotel, but you may have a situation where you want to take it out. The most important thing is going to be the HVAC. We're trying to achieve negative pressure either by room or by floor, and that is to control the infection. The other things important in any of these facilities is emergency power, and so that's noted on there. Next chart, please. What you're looking at here is a typical ground floor plan view of a hotel, and so what we tried to do here is articulate the functions. There's nothing special about necessarily the where on this chart, except that these first two charts are laid out in the concept of one clean side and one dirty side when you're talking about taking care of infection control and donning and doffing of PPE. But certainly starting in the top left there, you need to allocate for areas for red bag disposal, medical waste disposal, the generator, moving on counter or clockwise there, the PPE doffing and donning area, patient drop-off, med gas storage, and pharmacy. Those are kind of the things that you got to consider how to lay those out and comply with local requirements. But the main thing is when you're looking at these is just getting the function laid out correctly. Again, the things in green are what we think are there already in a hotel. The things in purple are some of the engineering changes, and in red is the equipment. Next chart, please. This will be a typical second floor plan view, floor plan, the same concept of trying to keep one side clean, the other side dirty in terms of infectious control. So you can see on the right side a clean stair and clean rooms, clean linen, and on the left side the dirty stair, dirty linen, as folks can don off as they go out into the decon shower and go out. So it really, all this is going to have to be worked out. The specifics have to be worked out with the local health officials on how they want to do infectious control, whether they're doing a whole floor negative pressure or just a room negative pressure, how they want to take care of donning and doffing of PPE. We just tried to notionally show here the functions that the team's got to take a quick look at, and in conjunction with the engineers and the health officials determine how to best set up the facility based on what's. Next chart, please. So this is just another option for a typical ground floor of a hotel. And this one, instead of kind of the free-flowing deal, there's an airlock you can see. So this one was kind of designed around having a negative pressure on the whole floor potentially and having an airlock in and out. But the same general concepts apply with the pharmacy, red bag disposal, med gas storage, et cetera. Next chart, please. Same thing, just a second option on a typical hotel floor plan. You can see the red lines in the middle toward the page, reminder gates. Those are just areas that would be located depending on where you want your defining line to be for a clean and dirty area. One other point I'll make here is, because it's come up in a couple of sites in arenas and hotels, is we're made the assumption that we're going to ride the existing Wi-Fi network and local area network, and so that right now that seems to be working out okay, but most all that falls into the equipment lanes that USACE is not taking the lead on. We'll certainly work with the local officials, but not the lead on that. Okay, next chart. So this is a civil site plan view, and the real takeaway here is in these hotels, they're not going to be just walk-up facilities. There's got to be a little security added. So you can see some notional connotations there on perimeter fencing and a kind of a makeshift access control point, re-emphasizing that you got to control access in and out. Local officials will guide exactly how they want that done, but it'll definitely be part of the scope. The generator there, red bag disposal again, some of the med gas storage and pharmacy, same concepts, but the takeaway on that one is access control. There's got to be a conversation. Over. Next chart, please. So we're going to transition from hotel into arena, the HQUSACE. And before I get into this particular chart, really when we came up with that concept, it's built around a variety of patient areas. It could be, and this is again speaking on a COVID positive worst case type scenario. So there's several options. We'll talk about a few of them in more detail later, but there's drop ship, commercial off the shelf, soft shell tents you can buy. There's drop ship, commercial off the shelf, hard shell models you can buy. And then we looked at a couple others, retrofitting packing containers we'll talk about in a minute, or pods, Connex shells, and then built-in place options. The one on slide 15 that you're looking at is built around the tent option, pop-up care space. And so this is for COVID patients. Big thing here is making sure it's large enough to house all the equipment you might need, the ventilators, telemetry pumps, other items you see there in red. The bedside toilet, assuming a particular acuity for patients, you're going to have to accommodate that. HVAC ducting and HEPA filtering, you've got to get a supplier in, and HEPA exhaust out. And emergency backup power, data, Wi-Fi, all that's there as well. Next chart, please. So this is just one of several example layouts depending on the kind of patient pod you employ. We did horseshoe concept here overlaid over a football field so you can see sort of the scale and dimensions. There are a variety of ways we're seeing this play out. And so this is just one of many nurse to patient ratio of 1 to 15 on this one. There's a variety of ratios depending on the acuity of the patients, and all those details will be worked out. The takeaway here is a lot of support facilities have to be put in place that aren't necessarily denoted on some of these. Same kind of support facilities, a pharmacy, PPE, donning and doffing, med gas storage, et cetera. A lot of other functions you got to account for when you're doing these concepts. Next chart, please. So this is one I talked about out of the four. This is a pod concept, taking existing container or Connex shells and retrofitting them into patient isolation pods geared for COVID positive patients. And so we partnered with our folks down in the Engineering Research Development Center, another center in the Corps, partnered with them. The pictures you see there are an actual pilot they did last week. It took about 8 hours and a small crew to put those things together once they got the materials. And so it's a small HVAC unit, like a PTEC unit on one end, a HEPA filter or MERV filtered exhaust on the other end, nice air drawn through. These containerized pod concept here is meant to be for COVID positive patients in an arena or a covered area where we're drawing in conditioned air from an existing arena. So this is a neat concept that's being deployed in several places now. It's just one of several options that you can utilize in this scenario. All right, next chart, please. Okay, I think that concludes my portion. I'm going to turn it over to Ms. Jill Stiglich, Director of our Contracting Group.
Good afternoon, everyone. I'm Jill Stiglich, and I'm the Director of Contracting for USACE. I also have our senior contracting officials on the line. Jackie Woodson is our SCO Alexandria, Laura Eichhorn, SCO Atlanta, and Denver Heath is SCO Dallas. I also have my key members of staff online, Colonel Robert Maselli, who's our Deputy Director, Jake Jacobson is our Executive Director, as well as Robert Baldwin, Wanda Cross, and Rick Jenkins, who are our 3 division chiefs. I think one of the top questions we're receiving from industry right now is, how can I help the Corps execute the mission? The first thing is that we need to know what your capabilities are. On the screen right now is the U.S. Army Corps of Engineers website. I'm asking that each of you go to this website if you haven't already done so. Click on the link at the top of the page entitled Contractor Responses to COVID-19. It's going to take you to the COVID-19 Market Research Request page link. Next slide, please. Just click on this link and provide your capability statements to us. Right now, across USACE, the districts and centers are executing a lot of market research. They're reviewing this slide as part of their analysis as well. The next slide is basically a process slide to let you know what happens to your email when you receive it. And this process is changing now and is now automated. So, hey, Robin, do you want to add anything about the new process or that slide over?
Yes, ma'am. We were very thrilled by the response that we've received to our market research request. And we're kind of building the plane like when we were flying it. So we started out kind of Dick and Jane, real easy, and now we've really gotten high tech. So the first 4,000 or so emails that came in, an email will come into an inbox. You'll see then it's we were working on automated response. I think we have that up and running. Then we actually have human interaction. So we have about 40 people right now or more reviewing all of the information that you have submitted. So what we have to do when we get that information, we have to see if there's everything that we need. And if everything's there, we'll thank you for your email, and your information automatically goes into our market research repository. If not, we have to send you back an email and ask for additional information, like we need your DUNS number, we need the state you're willing to perform in, if you have information immediately available. And if not, if we're going to respond to you, and then if we get that information back, then we can put your information into our market research repository. But as soon as we have that, the information is available to every contracting and technical professional in the Corps of Engineers. So what else are we doing? On the website that Ms. Stiglich showed you on the previous slide, we've now changed it to a web link, and that will allow anyone new coming in to enter their information in a form, and the form automatically goes into our repository. And we are, right now we're working with the Digital Defense Service as well as Army Futures Command on making our market research tools even better. So it's amazing when you ask folks for help, they'll come and help you. So, and we're doing this with procurement analysts. So I want you to know it's not anyone, they're trained professionals, GS 13 and 14 procurement analysts doing this work of reviewing what you submitted. So we thank you very much. Thank you, Ms. Stiglich.
Great. Thanks, Robin. Can we go to the next slide, please? Okay, we had a couple questions that I'm going to go through. We keep getting a lot of questions, obviously, but these are the ones that stand out. And the first one refers to the Stafford Act. Our contracting officers with the boots on the ground review each mission assignment very carefully. And then preference under the Stafford Act is given to the extent feasible and practicable to those organizations, firms, and individuals residing or doing business primarily in the area affected by the major disaster emergency. In the case of COVID-19, The area affected by the emergency is nationwide. So one other item that is really being considered, I think it's very, one of the top considerations besides the contractor's capability, is that the ability of that contractor to respond immediately to the situation. In most cases, we cannot wait for a contractor to mobilize. So capability and responsiveness are definitely at the top of our list. The next question, I think that each state is going to vary on its own unique COVID-19 missions. We receive a mission assignment from FEMA. Generally, the state is going to decide along with FEMA which actions it's going to execute prior to requesting support from USACE. In many of these cases, USACE is actively engaged in all of these discussions, and in some of them, we're not involved. In the end, we recommend that each of you reach out to the states as well if they're executing many of these actions on their own. So next question. Okay. We really, really appreciate the willingness of our industry partners to contact us, providing information and their capability statements related to our mission. As of yesterday, I think Robin alluded to this, we received 4,200 messages from industry, and that is as of yesterday. We're going through each message with a team of 46 contracting professionals. We had to bump that number up from 15 to 46 to be able to respond to everybody. We're still contacting those individuals and firms, responding where we need additional information, and like Robin said, such as phone number, cage code, company name, and that kind of thing. I'm finding that each day we're finding better ways to receive and assimilate the industry market research. And as previously discussed, last evening we upgraded our site to a form rather than just an email, and I'll read this kind of slow. It's https://usace.army.mil/business-with-COVID-contracting-form. Boy, that was a tough one. Let's see. Yeah, Robin alluded to the fact that we're working with Futures Command and compiling all our data, so we've got a bigger audience that this information can get out to. Next question. Okay. All right, each day our awards for the alternate day care facilities. All that information is posted on the USACE public website. If you click on the COVID contracting, and the information is on the main page. I've got a direct link. The same thing, https www.usace.army.mil business-with-contracting. Okay. And I think that's it. Over.
We thank you guys all for your time so far and all the presentations currently. We have received questions, and we're going to start taking them, we'll start with the first one that I have for the group here. Industry is planning teaming arrangements to execute recently prepared alternate care site standards. We are curious what contract types are anticipated and being used currently.
Okay, this is Jill from contracting. I would say that the specific facts of the mission assignment is going to drive the acquisition approach. The districts or centers will determine which approach is best, but there will be a combination of the execution against existing tools as well as issuance of letter contracts as appropriate for the circumstances on the ground. Again, it's going to be determined upon what the requirement is. Over.
Great. Thank you very much. The next question, who is doing the design work and who is the designer of record? The USACE website indicates that the general scope of work concept layouts and performance specifications are to be used by the states and municipalities to prepare a list of design deliverables. Now that USACE is directly contracting for this work, how are design decisions being addressed?
This is Chris Altendorf, Chief of Engineering Construction, and I'll take that question on, and if Wade wants to pipe in when I'm finished, he's more than welcome to. But as I stated originally, the designs that were discussed in this briefing, they're conceptual designs. It's when we were trying to really get out ahead of things before everything went totally crazy. We thought, hey, how can we actually provide help? Even before we got some assignments, we were like, hey, what can we do? You know, we do have a medical center of expertise down in Huntsville who did a lot of these designs. And but they're conceptual in nature, and the states and the municipalities are by no means forced to use these at all. These were what we thought would be a good idea, and a lot of people have latched onto them. So that being said, even with our districts, they take these designs, these conceptual designs and plans and specs, and they then mold them to what is needed for their particular site, for their particular location, to their particular kind of medical experience that they're trying to fulfill. And so every single contract that's awarded that we're doing is probably a little bit different from what the concept design is. Like I said, this is just a base and a guideline, and then the districts that award it, especially obviously where the Corps of Engineers is doing the work, they will then take the responsibility along with the contractor that it is awarded to as the designer of record, with the Corps of Engineers doing the review, obviously, if it is our contract. And like I said, where the states are using our designs or maybe not using our designs, then that falls into their area, and then they will take full responsibility as those things move out. Wade, I don't know if you have anything to add.
Yes, ma'am. I'll follow on there just a second. I mean, with this decentralized execution, which is really the only way we can do this in a timely fashion, and it's going to depend on the language and the local contracts that the districts do, but there will certainly be a contract that is tasking a constructor and maybe an AE partner that they're going to have some designer of record responsibility, particularly for the fire protection systems and life safety and some of those things. But back to my earlier point, I think you're going to be in a three-way huddle with the local authority having jurisdiction. So I think everybody's going to have a piece of responsibility. But what we're finding, because of these temporary facilities and the timeliness required, the AHJs out there are taking on a risk that they normally wouldn't take on. But there's still some responsibility for our constructors and our AEs as well in a designer of record capacity, if that makes sense. It's just going to vary locally. Over.
Great. Thank you, Wade. The next question, industry firms are unclear on USACE's process for soliciting, evaluating, and selecting awardees. How are awardees of these facilities selected, and how are their capabilities considered in this process?
Okay, sorry about that. As I stated earlier, each district and center is going to determine which acquisition approach is best given the uniqueness of the requirement. And I'm going to give any of the SCOs an opportunity if they want to add anything else onto it. I know you guys are more boots on the ground, so if you have anything to add, please feel free. Over.
This is Laura Eichhorn, so for Atlanta, yes, we're using a variety of approaches. Most of the requirements in my area, which is everything east of the Mississippi, we're doing through a design-build limited source competition. So a phase one solicitation is issued to limited sources based upon market research. We then down select to a phase two pool and make awards for individual projects from that pool. We also have other tools within USACE that can be used. There's a RDI program out of Omaha, Denver Heath, can do that better than me. And then we also have MRR contracts out of Huntsville. That's medical renewal and repair, I believe it stands for, and they have available capacity as well. So with each project, you look at what's required and determine which approach is going to best meet our needs. And with our design build tools that we're using, we're certainly doing what we can to try to consider local businesses to the maximum extent possible.
Great. Thank you, Laura.
So, ma'am.
The next question. Oh, go ahead.
I'm sorry. This is Denver Heath. I think Laura laid that out very nicely. The only thing that I would just like to add is we're working in an urgent and compelling or unusual environment here. And so if you're used to working with the Corps of Engineers when we're not in an urgent environment, we'll take 15 days to announce a requirement. We'll take 30 days to receive a solicitation. We'll go into an evaluation process with boards. We'll hold multiple rounds of discussions, and then months later, we'll emerge with a contract award. The environment that we have here with COVID-19 being a life safety environment, the districts and the centers on the ground are working under unusual and compelling urgency, which means they're going through that process in a matter of days. It's not even a week in terms of selecting a contractor and moving forward. From the point of a mission assignment and a tasking order from FEMA, our job is to make sure that we're selecting the best contractor available that can respond in a robust manner and get them on site as quickly as we can. And that's why it's so important for you to provide your information from a market research perspective on this website, and then also to the local offices who are doing source of salt right now. We are in various stages all throughout the country right now. Some are in execution mode, executing actions that have already been assigned. Some offices are waiting on mission assignments from FEMA and tasking orders. And so that's why you see the differences in some executing actual contracts and others executing source of salt and doing more market research. So please provide us your documentation on the website, and because this is an urgent environment. Over.
Great. Thank you, Denver. The next question is going to relate to changes and modifications to the general scopes of work. We understand that site adaptations are a necessary part of this contingent operation. As changes to the configurations for the arena to healthcare and other alternate care facility concepts are made, such as the isolation, pod configurations, HVAC, med gas, and power. How have these changes been documented and incorporated for future procurements?
Hey, Mackenzie, this is Wade Doss. I'll take that one. The short answer is yes, we have been incorporating feedback from the field into these concept sketches and performance work statements and equipment list, et cetera. The core team has been established for a couple of weeks now that came up with the concepts, and we've established points of contact for each of our major subordinate commands, and so they're feeding all their lessons learned back through us. We've also set up a lessons learned site on the Corps of Engineers Knowledge Management portal, and so all the districts and divisions are sharing information that way as well. And we've got a little more formal mechanism to take RFIs from the districts. So we're trying to archive all that and use it as we go, but the short answer is yes, we're trying to take those and modify. And version control is a challenge, but yeah, at some point we'll call the ball, but we're still taking a lot of feedback and trying to push out new updates to the website as appropriate. Over.
Thank you, Wade. The next question, have there been or do you anticipate doing any hotels to healthcare projects?
This is Chris Altendorf again, and I'll talk to that, and anybody else can pipe up if they want from. But from what I have seen so far, we actually, for an actual hotel, the Corps of Engineers has just awarded one of to an actual hotel, and that was in St. Louis. But out of the 2021 that we have awarded so far, 7 actually have used that design. Now that design is, it could be for an old, maybe an old hospital that has been shut down, or a dorm, or another facility like that. But for us, only one actual live hotel, if you want to call it that, obviously that was shut down for coronavirus impacts, is all that we've actually done, but we're using 7 of that typical design throughout. Over.
Great. Does anyone have anything else to add from the panelists?
Yeah, Chris, this is Mike Schultz. I would add, as we started early on in this process and we're just starting to develop the hotel to healthcare option, we had a couple that Health and Human Services had put in place, the Public Health Service had put in place out in California. And so there was some real on-the-ground sort of, they were already operating, had already gone through that process. So we used those two examples to help frame our original concept and think through how we would do that. And so that helped us sort of jumpstart from getting that concept in place rather than just starting from a clean sheet of paper and no idea. And like Chris has said, we're starting to see that directly applied to one hotel in Lewis, but we've seen them take versions of that concept and apply it to some dormitories, existing hospital spaces, and other spaces other than arenas. That's it. Thank you.
Thank you, Mr. Schultz. The next question is going to be related to CM services from the industry. We have not seen any awards for construction management services to date. Will you be soliciting these services?
I'll talk to that since I'm the E&C chief. This is Chris Altendorf again. So as I stated earlier, these are quick from flash to bang, and so they are, anywhere from 5 days to 2 weeks from, to actually being constructed. So right now, with our capacity, our in-house capacity for as quickly as they're occurring, and this goes, like I said, for our projects, we're using our in-house personnel like we would on our regular projects. So whether it's ACO or it's construction managers we've got out in the field working with these, we're doing the oversight on that. I cannot speak actually to how the states are doing it, but like I said, depending on, they probably do it how they normally do any of their construction projects, and I don't know. I would make the assumption, if this is an assumption, that they probably don't have the in-house manpower and that they probably contract that out, but the Corps of Engineers with our contracts is using in-house manpower. Over.
Great. Thank you, Dr. Altendorf. Unfortunately, we're running out of time, so we only have time for one more question, and then I will do a quick little closeout. The last question is USACE requiring traditional cost accounting standards when cost contracts are used?
Okay, this is Jill again. Yes, CAS requirements are still in effect right now. We do understand that there's a lot of firms that do not have an approved cost accounting system, so we have asked for a class deviation for all COVID-19 awards, and I think this will be a big help for the small businesses and, construction contractors who normally don't do cost-type contracts. Over.
Great. Thank you very much, Ms. Stiglich. That was all the time we had for questions. I wanted to tell everybody thank you guys for all attending. We have received all of your questions in the chat and the email, and we'll be posting responses to additional questions that we didn't have time to answer on this call on the website, as well as posting the slides and the video of this WebEx. You'll be able to see those under the USACE public website under the coronavirus response side. Thank you all for coming. We appreciate your time and look forward to working with you guys in the future.